Okay, Assalamu alaikum. Thank you, Dr. Abdullah for the kind introduction and invitation. So today I'll present a single case, a case that's supposed to be an elective TAVI case, but with our help, we achieved the emergency status. So we'll show you the case, how things went. So our case is a 74-year-old female. She's from Yemen, and she has a very poor socioeconomic status. She is known to have three-vessel disease. She has an NSTEMI about 5-6 years ago, and she was diagnosed with three-vessel disease. She was referred for surgical intervention, but she was lost to follow-up. She has multiple cardiovascular risk factors, including diabetes, hypertension, dyslipidemia, and she does have old CVA, but no significant neurological deficits. Her echocardiogram showed dilated LV with LVEF of 30%, moderate MR, and severe AS. That was at the time when she was admitted with recurrent non-ST elevation myocardial infarction at a periphery hospital. They did the echo, and she was discharged on medical therapy and referred to our clinic for further management. This is her echocardiogram on admission, and you can see she has a dilated LV, very severely stenotic aortic valve. We did a CT TAVI as a usual TAVI workup. She has an annulus area of 365, perimeter of 69. She has adequate coronary height, and she has acceptable bilateral femoral arterial access. So we do have a transfemoral TAVI as an option for this patient. So we did a heart team meeting to decide whether this patient should go for surgical intervention, surgical bypass, and surgical aortic valve replacement versus PCI and TAVI. So just show of hand, who would send this patient for surgical intervention and with surgical aortic valve replacement? Okay, no one? Who would send her for TAVI and PCI, since we are a PCI team? Okay. So obviously the patient refused surgery 6 years ago. She's going to refuse it now. She's actually very frail. So we agreed that she should go for PCI and TAVI. This is her coronary angiography. This is the injection of the right, which is a known CTO from her previous angiogram. You can see that the left system is calcified proximally, and there is, I don't know if it projects really well, but there is a severe proximal LAD and severe high OM branch stenosis. So essentially she has three-vessel disease. So now we are thinking about the strategy of this patient. We're going to do both. We usually do our cases, we do both at the same setting. We do the PCI and the TAVI the same setting. But the question is, would you start with the TAVI or would you start with the PCI in this case? So who would start with the TAVI? A single person. And who would start with the PCI? Okay, majority would start with the PCI. Okay. We will discuss that. I think that's an important discussion point in this case. So I think we agreed with the majority. We said we're going to go ahead and go ahead with the PCI, then we'll do the TAVI. And I'll explain later why we made that decision. So we started with the LAD. We pre-dilated. Despite looking calcified on the angiogram, it actually opened with the even regular compliant balloon. We did pre-dilate. We put a long stent. And let me show you back the final result, if it will play. So on the right-hand side, you can see that's the final result. It was a very nice result, considering the small vessels and diffuse disease she has. Here I used a microcatheter to access the high OM. And we need to focus here because that's where problems start. So with a long compliant balloon, you can see that there is a segment that's not yielding. So it's a non-dilatable lesion. Then went ahead and I had to use a guide liner. You can see I'm pushing a non-compliant balloon to get it down, even though it's a proximal segment. But I think the angulation and the tortuosity just with the calcium is a very bad combination. So I had to use a guide liner. I was able to get a compliant balloon. But despite going to a really high pressure, around 25 to 30 atmospheres, the segment is still not opening. So at that point, I decided to go ahead and take a cutting balloon. In my opinion, usually if you can deliver a non-compliant balloon, most of the time you are able to deliver a cutting balloon, which is probably the easiest. So here you can see the cutting balloon doesn't want to go down. And at this point, the patient's starting to become hypotensive, restless, because we do our cases under local anesthesia, and I think that's one of the advantages. The patient starts moving, you know something wrong is happening. Because once you put a guide liner in, the pressure usually is damped, so you really don't know, is this because you have a guide liner in, or is the patient getting worse? But at this point, clearly the patient is becoming agitated, non-stable. So I pull everything out, and seconds after this shot, the patient arrests. Okay. So patient arrest, CPR is ongoing. What would we do next? I guess, would you just continue with regular CPR and see what happens? She's 74 years old, frail, multiple risk factors. We have one voter here. Who will put this patient on ECMO?
So Abdullah, can I just, before that questions, would you, at this stage, would you say to yourself, I should have put a hemodynamic here, or before I do a PCI, or not? Did that come to your mind?
I'll address your question. You want to?
Yeah, just quick note. Now, the last injection showed that distal left main was a concern. So, because, you know, that circa, you know, it's a good size, but, you know, I would have doubt that it would cause a hemodynamic collapse. You see distal left main?
Yeah.
Like, did it come across your mind that probably just crossing in an LAD and stenting back into left main would be a reasonable approach?
So there's no doubt there is a distal left main, but the other projections, it didn't look as bad, but I think it does have lesion, no doubt. And I think what happened was the guideline was occluding the flow to the LAD, the RCA is occluded, and you are working on a vessel that's not opening. So you have a generalized ischemia and someone with severe AS with significant LV systolic dysfunction.
Walid, do you want to say something?
Sure, that's the problem. Due to ischemia, and we're already starting with reduced LV function, I think now the contraction is unable to open the aortic valve. So that's, I think with that, going quickly onto hemodynamic support and ECMO will be the right.
Yeah, but difficult because you didn't do the TAVI, you know, that's what my question was. You know, I think Dr. Hatem here meant to start with TAVI. So this is, I know it's a dilemma, but at this stage, you know, I know PCI would have been, but now you've said to yourself, I should have done TAVI maybe before the intervention.
You know, in hindsight, everything becomes clear and easy. But to be honest, we didn't think it's going to be we underestimated the difficulty of the case, let's put it that way. But it turned out to be a very complex, very high-risk case for all the reasons. You have severe AS, you have significant LV systolic dysfunction, and you have 3 vessels, and you're working on the left system with the right that's totally occluded.
Absolutely. So just take 2 comments here, quickly, please. Yeah.
I agree with you. I think the guideliner definitely, affected the flow, and it was occlusive, and you were trying with several balloons, and it was going on for a long time, and that's why she decompensated pretty fast. I have a low threshold when it comes to calcific lesions, is to go with rota. The rota is a very powerful tool. I think if you didn't go with the guideliner and just went with the rotablator, you might have not been in that situation. But regarding support, if you thought you needed support, it's a bit tricky, but you could have gone with an impella. I know it will be difficult to go across the aortic valve with an impella, but it's been done before. You can balloon dilate the valve and you go with impella and you have support. But in this case, I don't think you need support. I think it was all the issue with the guideliner being inclusive.
Okay.
So I agree with the first comment that, you know, we always talk about lesion preparation. That's no doubt. But there is the phenomena of doing PCI at the time of TAVI. You're invited for TAVI. You're not invited for PCI. So you just want to get rid of the PCI and do the TAVI. And that's a real thing. And this is one of the things that makes me rethink about these cases where PCI maybe should be done as a separate session. The other point I don't really agree with is putting an impella in a severely calcified aortic valve. I mean, if you dilate the valve and you have severe AR, the patient will arrest on you. It's not advisable. If you're going to put anything, maybe a balloon pump.
Beautiful. Hatem, then Fikri. Hatem, please.
Yeah, sorry, just a quick comment. There is no right or wrong answer here, I don't think, especially when the patient is being, or the procedure is being done by an experienced operator. But this patient checks all the boxes for potential badness happening during the procedure. Elderly, frail, triple vessel disease may require rota. severe AS, limited myocardial reserve. I actually don't think that putting an impella right off the bat is a bad idea. You don't need to dilate. You will cross the valve anyways, just cross, put the impella, and then do whatever you need, even if you needed to roto it. And it has been done and described before.
Fikri?
First of all, it's a very high risk case, and the arteries are coronaries are severely diseased and calcified. So I think if you decided to do the coronaries before the TAVI, then you should, prepare the lesions very well before doing angioplasty. And in my experience, crossing with a cutting balloon, a calcified lesion, I never succeeded to cross. It's very, very challenging to cross a calcified lesion with a cutting balloon. Maybe with a scoring balloon, but definitely rotablation here is a choice, a good choice to start. Especially the obtuse margin has an angle, which makes it difficult for possibility, going through with a balloon or even a stent after that if we cross with balloon.
Points worth taken. I will tell you at the end what I think if I was going to do this case again, how I'll do it differently, because that's how we get experience from doing the cases. But the problem with this being very tortuous, that increases the risk of using atherectomy. The risk of perforation is actually high in terms of a very tortuous vessel because you have a wire bias with the rota. So that's one of the things to keep in mind also. But also it's difficult to deliver cutting balloon, which we had. So there's no easy answer. But I will show you what we did.
Abdullah will take a comment here.
Okay.
Just quickly, it's very hard to put the cutting balloon in there. This angulated is very tough. I will not even try it actually. But what the thing sometimes I do, just put a couple of wires next to non-compliant balloon. You have non-compliant balloon already in there, and attach to it a couple of other wires. So your balloon now is working as a cutting balloon. I found it very effective, very easy. But really, the blade you're going to put inside is really very tough to take the curve. I mean, if it's straight, probably, but for the curve, it's really.
I do use this technique sometimes. The issue here, we didn't have time. As soon as we pushed the cutting balloon, the patient arrested. And I think what I should have done in this case is every time I remove something, I should have pulled the guide catheter extension back in the guide, do the exchange, and then introduce it. It was there all the time, and I think that was part of the problem because I was more focused on crossing the lesion. Okay, so we'll move on. So the patient arrested, so we put an ECMO. So as you can see, there is the venous cannula in the right SVC. You can see there is a pacemaker now. We crossed the valve, and you can clearly see that the heart is not moving at all, which is really good when you're implanting a valve. So this is our position of the valve. You don't really need to pace the heart in this condition. And this is our TAVI valve being implanted. Okay, so the valve is implanted now. Would you stop at this point and leave the patient on ECMO and let her recover, or would you proceed and fix the circ? So show of hand. You will stop at this point? Okay. Few people, so I guess most people will proceed with fixing the circ, right? 50-50, okay.
Just a quick question about this circ. I mean, perhaps do the LAD, secure that at least major part of her revasc, do the TAVI, and then bring her again for a second procedure, second stage procedure, because those patients, you and I know quite well, that they don't tolerate long and the process, don't they? So that's why revasc on those patients sometimes can be delayed till later afterwards. I would probably left the circ completely. I've done the LAD, secure it, then do the TAVI and bring her back another day. The circ is not going to kill this lady. This is what I would have done. I think always it's easy in the hindsight, as you've mentioned,
yeah.
But I wouldn't have done the circ for this lady. Or you can do the Shimini technique, as you and I know quite well. During TAVI, you can place a wire down, leave the stent in place if that goes round. I mean, obviously, you won't go in this case specifically.
So, Shimini technique, you do it if you're concerned about left main obstruction, which is not the issue here. It's not the issue. We are not concerned about the left main because the CT, we know the coronary height was good. That was not an issue. So the chimney will not work in this axis. But the problem, the problem with your approach is to only fix the LAD. Now you only have patient living on a single vessel. Your circ is severely down and your RCA is down. So if you have a stent thrombosis, and this was a diffused vessel, long stent, having instant restenosis can be very risky. Anyways. It's a different approach. You can do it either or. What we did, usually if I put an ECMO, I will utilize it as a mechanical support to fix everything. Because we have the ECMO there, this is the best situation to fix it. So we I went back, I took a picture, and then I did what I should have done from the beginning. I put a microcatheter, and I used orbital atherectomy. And the reason I used orbital, because I find it more gentle on the vessel, and because of the tortuosity, I didn't want to use rota and cause perforation. As you know, complication begets complications. So I was trying to be cautious. As you can see, the rota crosses the lesion, and then this is the second run to show that it's moving really smoothly without any tension. And here I'm introducing easily introducing the compliant balloon. I'm doing a test. I'm going to pull the non-compliant balloon back, and you can see as soon as I inflate it, it opens at really low pressure, which we should have done from the beginning. Anyways, it opens. This is the stent. This is the final result. Okay, are we done, or do we need to do anything else?
How's the patient?
Patient is very stable at this point, and you can see the heart is already moving. Okay, so I took a few pictures, make sure everything looks good. The distal left main doesn't look as bad in this view, if you can see. So it does have a lesion, no doubt, but putting a stent there is going to make it a complex PCI, which you really don't want to do. And then I put a balloon pump. So that's the last thing I did. So CCU, patient was improving. Pressors were down titrated, lactate, mixed venous were very good. EF improved again back to close to baseline. And 48 hours, we removed the ECMO. In our center, interventional cardiologists, we insert the ECMO and we remove the ECMO. But one of the issues that happen with removing the ECMO is sometimes you get femoral artery occlusion from the proglides. But this was dealt with ballooning and was fine. So patient was improving in the hospital, extubated 2 days after the ECMO, then the balloon pump was removed. Total stay of around 14 days, so 2 weeks, 7 of them in the hospital, in the CCU, 8 in the ward. This was at the end of January, so we saw her a 1-month follow-up. She's doing really well, considering how she looked like. She's totally independent with EF and around 45, so it's improved even further because we opened the vessels. So, I mean, there's lots of discussion points. We've already discussed it. This case generates a lot of discussion. TAVI and PCI, what's the best approach in the same setting, which one to do first, and the importance of having a VA ECMO. That's what saved this patient in the cath lab. Just one last slide. This is the way I think about which one I do first. This is my own thinking of how do I do these cases. I thought this was not very complex PCI, and I thought the patient was stable. I didn't have concern about coronary access, but the patient had significant LV systolic dysfunction. So 2 things favored PCI, and 1 thing favored doing the TAVI first. That's why we did the PCI. But in retrospect, it was a complex PCI, which if we appreciated the complexity, we would have done this case differently by doing ablation, preparing the lesion really well with the circ, and doing the PCI. And I would have done the TAVI first, because I didn't have issue with the coronary access. Do the TAVI and then do your PCI, especially you're going to do a complex PCI with rotablation. Thank you for your attention.
Excellent. Thank you very much, Dr. Abdullah. It's been discussed already. Thank you. So we'll move to the next.